So the first part of what I want to do is to give you our thinking on patient-centered outcomes research. As I said, I don't have to spend much time on this because through the award, you clearly have got it down. Second is speak to you about the kind of the updated and evolving funding mechanisms at PCORI. They are evolving some, and you need to know that. And the third is to talk a little bit about embedded research. Again, I feel like I'm preaching to the choir, but maybe it will at least affirm your sense that you're on the right track and doing the right kind of research. So I take you through the evolution of what we've meant by patient-centered outcomes research. And just because we kind of move on doesn't mean we disavow what we said before. So by the time I arrived, I got there in July 2011, and they were just finished crafting this statement of what is PCOR. So it answers the question, given my personal characteristics, conditions, and preferences, what should I expect will happen to me? So really personalized prediction and estimations of risk. What are my options, and also estimations of the benefits of particular therapies, given who I am. Number two, what are my options, and what are the benefits and harms of those options? So that's comparisons of treatment options. What can I do to improve the outcomes that are most important to me? So a nod toward alternative approaches to behavior change. And the fourth is, how can the healthcare system improve my chances of achieving the outcomes I prefer? So that's the recognition that systems research is a very important part of PCOR. A little bit later, we expanded on this a bit, and we said that PCOR compares two or more options for screening, diagnosis, treatment that matter to patients. So the important part here is that matter to patients. So we don't want an esoteric comparison. We really don't want comparisons that haven't been tested somewhat previously, and really pretty much we're getting down to which works better in practice, which of the available options works better. That considers the range of outcomes that are important to patients. So that's critical. We're looking typically for a larger range of outcomes, or outcomes that haven't been measured before, outcomes that are important to patients. I do not mean patient-reported outcomes, and I'll make that clearer in a minute. The third is that they are conducted in real-world populations and real-world settings so that they will generalize reliably in a trustworthy way to real-world populations. And the fourth is that they do attend to differences in effectiveness and preferences across patient subgroups. So you'll see that all of our announcements ask you to pay attention to the fact that whatever you're evaluating may not work the same in everybody. Ultimately, this kind of takes us to what people call personalized medicine. So I want to say a word about what patient-centered outcomes research is not. It is not research on patient-centered outcomes. And I'll tell you why in a minute. So some people think that the only thing that PCOR wants to fund is research on novel outcomes that people have never studied before. And that's not true. We want to include those outcomes, but we certainly do not want, we're not about conducting research simply on novel outcomes or outcomes that are in some way patient-centered. We want outcomes research that is patient-centered. And the outcomes are, whether the outcome is mortality or reinfarction or readmission or recurrence of cancer or progression of dementia, that's, or quality of life. That's what we're looking for, is meaningful outcomes research. And why? Because we don't want to get into this argument about, is symptom status a patient-centered outcome or ability to function? What about rehospitalization? Is that patient-centered or not? I don't want to have that discussion. Out-of-pocket costs, we would say those are almost always patient-centered. Mortality, we would say that's almost always patient-centered. Maybe not the top priority, though, in some advanced illness. Blood pressure level and hemoglobin A1C. How do we want to have a debate about whether one or the other or both of those are patient-centered? I don't. So you make the case in the individual study, the individual population, the individual comparison, and you tell us why it matters to patients, and you show us that patients are telling you that it matters, and we'll be happy. How do we get to patient-centeredness? Well, you are onto this too. Engagement, we involve patients, but we also involve clinicians, family caregivers, payers, delivery system leadership, researchers, policymakers, all as well as industry in all aspects of what we do, from selecting topics and prioritizing research. Those are our advisory panels, to reviewing the applications. Those are our merit review panels. They're multi-stakeholder. To conducting the research. You've got to have patients and other critical stakeholders, relevant stakeholders, on your research team. And why do we do that? Because we believe, I'd say the primary reason is that it enables us to get the questions right, to conduct the study right, to analyze and interpret the data right. We've got people from the beginning working with us to help us disseminate. And this is where we're beginning to see that this actually works. And we have people around as well. We involve patients and stakeholders in evaluating our portfolio of research and identifying the gaps and moving on to the next generation of research. And I'll show you that in a moment or two. We ask patients why it's important to engage with them in research. And this is what they said. We bring the lived experience of the condition disease, or we may bring experience of suboptimal care. We point out the research questions that do matter to us, the outcomes that are important, and the focus on patient-centeredness, ethics, safety, and urgency. We provide connections to other patients. We facilitate recruitment and also dissemination of research findings. We help to build trust and a sense of legitimacy in the research findings. And we provide a greater likelihood that the research findings will be useful and taken up by the patient community. So there is that word, useful, again. This is not new. We did not discover this. People have known it long before PCORI showed up, although we have not practiced it in healthcare research very much. If anywhere, probably here it's been practiced before. But of the 10 principles that Google follows, their number one principle is to focus on the user, and all else will follow. And for us, the users are the patients, their caregivers, clinicians, and others who are involved in healthcare and face choices and important decisions and need the help of focused, useful research. So as I said, we put these stakeholders, patients and caregivers, and all the others into a number of advisory panels. The first three are related to three of our research priorities, and they actually help us, they go through a formal prioritization process, picking the topics that we're going to put special dollars toward in our targeted announcements. We have an advisory panel dedicated solely to patient engagement because it's so important. There's a lot left to be learned and a crucial job to do in evaluating whether it makes a difference and what works there. We have a clinical trials advisory panel, and we have a rare diseases advisory panel. Each of these follows the formula of bringing in patients and caregivers along with clinicians and payers and others. Just three quick examples. This is an example from Merit Review. We received an application on the cardiovascular health of women with a recent history of preeclampsia. The merit reviewers, the patient and stakeholder merit reviewers gave feedback on the initial submission that resulted in substantial changes in the engagement plan and the study design and a success at resubmission. They suggested that they also provide the intervention in Spanish, and the authors did so, and also involved the National Council of La Raza as a partner organization. They made the intervention available via a mobile device. That was a modification, and they engaged more primary care providers through the National Association of City and County Health Officials as a partner on the research team. Here are some examples from planning and study design. So in a culturally tailored diabetes prevention program project, there was a suggestion from the patient members of the research team to add a male-only DPP group for an American Indian study population. In a pediatric diabetes project, the research question was actually identified by an adolescent with diabetes during discussion with the PI. The research question and the outcomes were later refined via input from patients. A separate advisory panel of youth, ages 8 to 12, and teenagers, along with parent partners, was formed. And in the Latina Breast Cancer Survival Project, patient partners were involved throughout, and they helped refine the eligibility criteria for the study and changed the design from including only women who had completed active treatment to including all women and their partners with breast cancer. And here's some examples of what we mean by engagement, some pretty amazing examples. On that cardiovascular health and preeclampsia example, they included ACOG, clinicians, policymakers, the National Association of City and County Health Officials, payers, Blue Cross Blue Shield, patient groups, and they found 4 patient organizations, and a consumer organization, babycenter.com, and the National Council of La Raza. On the Contraceptive Decision Aid Project, they partnered with the National Campaign for Preventing Teen and Unwanted Pregnancies, and this campaign lent their name the Bedsider Campaign. They built a decision aid and branded it with the Bedsider brand and used the same formatting, language, and look of Bedsider projects for this decision aid. And the Sleep Apnea Project, they're testing an intervention which is a support tool to increase compliance with CPAP protocols. The stakeholder partners included representatives from clinician professional societies, CPAP manufacturers, and Medicare and Medicaid to get early buy-in. So we stick to the notion that it does make sense to bring all the relevant stakeholders to the table. And when we encounter notions that either the payer community or industry is somehow shouldn't be here, we push back hard, and we will continue to do that. So that's it, and as I said, I think you guys have it about as good as anyone does, what we mean by engagement and patient-centeredness and why they work. So on to funding. In the very early days, back in the end of 2011, we issued our first funding announcement called Pilot Projects, and these were relatively small, up to $250,000 per year for 2 years, and they were basically focused on methods of doing patient engagement. That's how we came to know Jack Westfall, for example, probably a number of others of you. A little bit later, we issued in May of 2012, we issued our first broad funding announcement. So this had to be CER. You had to describe patient-centeredness. You had to describe engagement. Any clinical area was open. You just had to tell us why it was important and patient-centered and likely to change practice. And these were $500,000 a year for up to 3 years. And those have been going on and on. We have about 300 of these projects funded now. In early 2013, we funded our first targeted announcements, and these were much larger studies on a particular topic area brought to us by our advisory panels. They had to be CER, they had to be patient-centered, they had to have a very robust engagement plan, focused on a single clinical area, rather narrow question. As I said, those could be, we've got one that's $30 million, the Fall Prevention in the Elderly program. The next, and this is the newest, and I don't think I could have told you about this last year, are the Pragmatic clinical studies, and you should really take an eye on these. They are taking up a larger portion of our funding now, and these are big. You've got to think big for these. These are CER. These are patient-centered, and you have got to have every relevant organization. We're not talking about individual patients from your medical centers. We're talking about the relevant organizations who both buy into the research question and will work with you throughout the study. We have a set of high-priority topics. They come from our advisory panels. We also mentioned the IOM 100, and we also mentioned ARC's future research needs. You can also make a case that another comparative topic is critically important. So this is up to $10 million in direct costs, about $14 million total, and up to 5 years in length, so big studies. I propose a co-funded study with another funder if you've got one in mind. Keep your eye on these. We're funding about 18 of these a year. So what has our broad portfolio brought us? It's very interesting that it has brought us a number of projects, numbers of projects in each of these areas. And I think you'll agree that they do have that flavor of being patient-centered. So proposals around supporting self-care and improving self-care, around caregiver support and palliative care. Under the Improving Health Systems, proposals on care transitions, telemedicine, patient navigators, collaborative care. Under Addressing Disparities, cultural language training, community health workers, self-management projects. And under Communication and Dissemination, a lot of projects on shared decision-making. So what do these have in common? They look patient-centered. They don't look like what many people thought we would be doing with comparative effectiveness research. So we're delighted with this portfolio. We continue to fund projects in this area. We do think the voice of the patients has been, and of clinicians has been represented in all of this work. But we do have designed the targeted projects and the pragmatic studies to get at some of these really crucial comparisons. We need to prove that comparative effectiveness research, as originally thought of, I think, by the framers of PCORI, has a place here and can make a difference as well, particularly if you do it in a patient-centered and engaged way. So I mentioned the targeted funding announcements. You probably know of these, but these are the ones that have been funded so far. I mentioned prevention of falls in the elderly, treatment options for uterine fibroids, particularly non-surgical treatment options for uterine fibroids, treatment options for asthma in minority patients, for uncontrolled asthma, comparative effectiveness research of various approaches to transitional care. This is mostly moving from hospital to outpatient or to another institution. Management of obesity in primary care and hypertension control in vulnerable populations. And I think this last one is just out now. It's actually managed by NHLBI. So you can find it on our website, but you can also find it through NHLBI. Each one of these is, I think they range from about $15 to $30 million in total cost, and some of them fund two research projects. The asthma announcement actually funded 8 projects. So, mentioned the pragmatic clinical studies, and I already told you that we're funding about 8 of them per cycle, or 6 to 8 per cycle, 3 times a year, so about 18 total. And the critical thing about these are that they address high priority clinical and health-related comparative effectiveness questions, and that they come from the list of high priority topics that's attached to the announcement. So we expect that a lot of them will be pragmatic clinical trials embedded in practices, and some of them will be large-scale observational studies. Just a reminder of what you can do to be sure that you don't get funded by PCORI. This is actually from another talk where they specifically asked me to address the dead on arrival question, so I recycled this slide for you. You could propose a cost-effectiveness analysis. We won't fund you and we'll reject your application. You can ask a mechanistic question or other non-comparative question. You know, what causes disease X? How does a particular drug work? Not interested. You can ignore the methodology standards that are easily found on our website and links in our application, or you can fail to involve the relevant patients and other stakeholders. Those are the main ways to be sure that you don't get our funding. So that's it, and I'll be glad to answer questions about PCORI funding in just a minute. The last thing I wanted to speak to is our attempt to make a major investment in embedding research more deeply in clinical practice, even the capacity to do large-scale research. So PCORNet, let me just see here. Okay, I think I got this slide slightly out of order, but that's okay. So PCORNet is PCORI's thus far about $110 million investment, and it will be augmented next fall with an additional $150 to $170 million. So it's the world's first network. It's not the world's first research infrastructure network. There have been others, but this is the first one that's been based primarily. We start with electronic health record data, not claims data. We go get the claims data, but this is started on a population defined by having been taken care of and care recorded in electronic health record. This network aims to support both large observational studies from clinical practice and embedded randomized trials. No other network has ever taken on the task of doing both. And this is the first network to seriously involve patients, clinicians from the delivery sites, and health systems leaders in governing and using the network. I see. I think I'm just going to say, well, this is a last slide from the funding announcement is just to say that the tallest spike is 2015, fiscal year 2015, so we're already in it. The largest amount of money that we commit will be this year. Just focus on the blue vertical bars. That's our research commitments in this year. And the light blue is the second commitment to PCORNet, but even taking PCORNet away, you'll see that 2015 is our largest funding year, and that comes in at about $450 million. And then the next years taper off a bit, and you see that the blue stops in 2019. Currently, that's when our authorization ends, and we will be talking with Congress in 2017 and 18 about whether we should continue. We hope that we have impactful, useful studies, and we can point to them and we continue. But the green is the expenditure, so it just shows that we would keep spending on commitments we'd made out through 2023. But we taper toward 2019 in case we don't continue. Okay, so here's PCORNet. I've already told you the three ways in which it's unique. We funded 11 clinical data research networks, and they are based in FQHCs, integrated delivery systems, and a number of them are based in academic medical centers, partnerships among multiple academic medical centers. Some of them are based in one of them is based on health information exchange in the state of Louisiana. 11 of those, substantial funding to each, and patient-powered networks, 18 groups of patients, each with a particular condition, and 9 of them rare diseases, 9 of them common diseases. Their jobs are to grow and become more representative, and in phase 2, their jobs will be to merge with the CDRNs and really build very large, activated, motivated patients of communities with single disease for participating in PCORI projects. And we have a coordinating center housed at Harvard Pilgrim at Harvard and at Duke. And they're the same coordinating center that coordinates a couple other very large data networks. And the beauty there is that our data network and the other two, we hope, will be able to work closely together. There's coverage pretty much throughout the U.S. I've certainly had some nice conversations with Canadians about finding ways to work together with you, and I hope that we can. One of our goals is actually to be able to rather readily partner with other data networks to study variations in practice, for example. But the other point to be made here is that nearly over 50 academic medical centers in the U.S. are part of PCORNet. Most large integrated delivery systems are part of PCORNet. So you likely either are connected to, affiliated with, or have colleagues who are affiliated with PCORNet sites. Keep an eye on us. Beginning next fall, we will be very interested in proposals from researchers not in PCORNet looking for partnered projects. So I started out saying, what is PCORI trying to change? These are the latest changes we're aiming to make. First of all, who's on the research team? Adding patients, caregivers, clinicians, systems leaders, payers, and policymakers as appropriate to the research teams. The kinds of questions that are asked. Funding only questions that matter to patients, caregivers, clinicians, and questions whose answers are likely to change practice. Changing the speed of implementation from sitting on the shelf for 17 years before it gets out and implemented into practice to, who knows, maybe 2, 3, 4 years. And lastly, changing the role of the researcher. This is a little extreme, but from savant to servant. And, I think we have this notion of the researcher as somebody who follows an internal muse, gets to know something hellishly well, and pursues it for life. And the review process rewards that. And if you can write a good preliminary data section and you've got a track record, you just continue on that track. I think the group that's assembled here today represents researchers who are already well on the way to be a servant of patients and a servant of those who need the research from a quote, air quotes, academic of the type I described to a researcher embedded in the community where you live and work. So those are my comments, and if there's a little time, I would be more than pleased to have a conversation. Thanks.